Good afternoon, ladies and gentlemen, and good morning and good evening, according to your location around the globe. A warm welcome to all of the participants to the Kinepict Academy webinar on DVA-guided CO2 angiography. Let me introduce Dr. Balázs Nemes, the head of the Department of Interventional Radiology of the Semmelweis University, who is one of our first users. And I am Szabolcs Osváth, CEO and founder of Kinepict. Our agenda today is that in 2 minutes we will give a short introduction to the DVA technology and the Kinepict medical imaging tool, which are going to be used during the interventions presented today. Then we comment on a 20 minutes video of 2 interventions done by Balázs. And the third is that you can ask questions. We are aiming to have this session interactive, and we would be delighted to get many comments and questions, so we encourage you to ask questions. And let me tell you how you can do that. Now, you cannot ask questions directly during the presentation, but after the presentation you will. Please send questions by typing them into the questions log window, or by clicking on the raise your hand icon on the right side of the window. After clicking on the raise your hand icon, please turn on your microphone, and at the end of the session, when we go to the questions, we will let you ask your questions. We saw a fascinating advancement in imaging, in X-ray imaging especially, which is big part due to hardware improvements. Now, Kinepict adds to the software improvement part by using advanced statistical algorithms and data analysis. DVA, the technology built in our product, the name stands for digital variance angiography, which implies that in its most simple form, we calculate an image by a statistical analysis of the pixels. What we do, we decompose the image series recorded during the X-ray angiography into pixels, and for each and every pixel we do a statistical analysis of the pixel intensity values in time, and then in the most simple form we calculate standard deviation, and then we combine the result in a standalone image. This is the DVA image. And then this technology is embedded in the Kinepict medical imaging tool, which is a CE-marked tool that can be connected to the X-ray angiography machines regardless of the manufacturer. Now let's take a look at the videos, and I'll ask Balázs to comment on what he is doing in these procedures and interventions. This shows how the pixel values change in an X-ray angiography image series when the contrast agent flows by, and we see that the pixel value changes more where we have blood vessels and less where there are no blood vessels. The change is due to, of course, the contrast agent in the blood vessels and to noise outside the blood vessels. Now, digital subtraction angiography just takes a mask image, the first one usually, and subtracts this value found in the mask image from all the subsequent images. Digital variance angiography, on the other hand, considers all the pixel values in the entire time series and does a statistical analysis, for example, calculating standard deviation, which will be larger in the blood vessels than outside the blood vessels.
So this is our first patient. She's a 55-year-old woman with insulin-dependent diabetes mellitus, smoking, and chronic renal failure in her medical history. The patient was not yet on hemodialysis, and the left-sided Cimino-Brescia fistula was made on 2 years ago on the left hand. The subsequent ultrasound examination proved that there is a stenosis on the venous side of the fistula. I don't want to go into the details right now. Everything is written on a screen. Now let's see the video. This is an ultrasound-guided antegrade brachial artery puncture, and after the successful puncture, a 5 French introducer was advanced into the artery, which was connected to the CO2 injector.
In the meantime, you see in the background that there are two images side by side on the big screen. On the left one, you will see the DSA image generated by the Siemens machine. And on the right side, you see the DVA image generated by the Kinepict software.
That was just fluoroscopy, and you could hear that noise. That was the CO2 injector, and the first image. As you can see, there is a high-grade stenosis at the site of the anastomosis and an additional stenosis on the venous side. Usually we use high-pressure balloon because those venous stenosis and anastomotic stenosis are very resistant to normal pressure dilation. First we use the 4 mm balloon. The lesion was crossed with a thermohydrophilic guide wire. This is the 4 mm balloon. First dilation up to 20-24 atmospheres of pressure. As you can see, the balloon is crossing the anastomotic size, so the radial artery is a small artery. We do not want to use a larger balloon at the anastomosis. Balloon deflation, and we had to remove the balloon just to be able to perform an angiography with CO2, of course.
You used CO2 almost exclusively, right?
In this patient, yes.
From
Yes.
the last check image.
I do a lot of supraaortic and carotid, so those are not candidates for CO2, but for lower limb and for these patients, of course. Let's do a control run. That hissing sound was the CO2 injector.
See again.
Yeah, you can see that the flow is pretty good at the anastomosis size, and there is a visible stenosis on the venous side. Now you can see it much more better.
From a technical point of view, you see the edges of the image, you see the result of the pixel shift which was done both on DSA and DVA images.
No, we had to use a larger balloon. This is a 7 mm balloon. Again, high pressure balloon. This is the largest one we can use in a 5 French introducer. So I selected this one, and we did 2 more dilations on the venous side.
Again, you get the DVA image extra on top of the DSA image, I'd say. You don't get less information compared to what's without the Kinepict medical imaging tool. You get an extra image and an extra possibility to view the blood vessels of the patient in better image quality.
Yet another control angiographic run. There is a stenosis which can be a result of the dilation, sometimes at the edge of the balloon. If you dilate a venous side, vasospasms can occur, so we introduce the balloon again and we did another dilation just to figure out is it an additional stenosis or just vasospasm. It looks like a vasospasm. As you can see, this injection, this final injection was performed with iodinated contrast material. This was just an early phase, so whenever we had the final result, we always used one iodinated contrast material injection just to be sure that nothing left behind. The second patient is an old man with multiple medical history, hypertension, CO2, COPD, atrial fibrillation, smoking. He underwent several procedures in the past, and the patient was admitted because of thrust pain and wound on the 5 finger of the right foot. As you will see, there was a diagnostic run before the procedure, and what we will see is the distal SFA occlusion and the occlusion of the proximally deployed stent in the popliteal artery. We started with an ultrasound-guided antegrade common femoral artery puncture using a 5 French introducer. Now the CO2 injector is connected to the introducer.
So again, on the left side you see the DSA image, on the right side the DVA image, and you can compare the difference in the quality.
So the femoropopliteal junction and the proximal popliteal artery is occluded. There is an already deployed stent which is occluded, and that might make the procedure more difficult. If we want to cross it, we have to stay in the lumen. If we go subintimally, we might not be able to dilate the stent. We cannot easily get back into the true lumen to cross the stent. We use the microcatheter and a V18 wire. This is the landing point.
Actually, these images, Siemens suggests for the CO2 module to use 7.5 frames per second, but all these operations were done at 2 frames per second.
Yeah.
So you could reduce actually X-ray dose as well. On top of that, you could actually get reasonable image quality with CO2.
Sure, at the beginning we used it without the Kinepict software, and because of the company providing the CO2 injector suggested to use the highest possible frame rate, we used the 7.5 because you have to summarize several images just to be able to see the contrast material, the CO2 contrast material well, which resulted in increased radiation, which is not good for a patient and not good for the personals. This is after the first angioplasty using a 4 mm balloon. We used a smaller balloon, not the 5 mm, just to see is there a dissection. Usually, if there is a good lumen after opening with a smaller balloon, we will stick to a larger balloon, and we try to avoid unnecessary stenting. It's visible that at the proximal site of the previous occlusion, there is a dissection.
Still done with CO2?
Yeah, still CO2.
And you see the dissection?
But I think we decided to do a iodinated run. I'm not a big fan of femoropopliteal stenting, and I try to avoid it as much as it's possible, using long balloon dilation and then the focal stenting, spot stenting if it's necessary. So we did iodinated contrast material injection. Maybe that dissection is not as prominent as we could see, but I do not want to go forward because this was just still a CO2 injection. And we changed to a 5 mm balloon, and we did another dilation. This is the final size for those vessels. And again, even with CO2, it's clearly visible that there is a dissection at the point when we started to open the occlusion. Okay, so this is iodinated contrast material. And as you will see, actually there isn't a big difference between the two images. The same nasty looking dissection can be seen at the distal SFA, so we decided to do a stenting.
The difference is smaller in case of the iodinated contrast agent between the quality of the DSA and DVA images, because with the iodinated contrast agent and this much X-ray, the images are good enough in DSA as well, and the improvement in lessening the noise doesn't add really much. But it's possible, as our studies show, to decrease actually the X-ray amount then, which becomes limiting for the DSA and good enough still quality with the DVA.
I think these are maybe the final images after stenting with a good result. And just to get back, at the time of long and complicated procedures, long CTUs, the increase in radiation is really high. Now we don't only treat just the stenosis, we have to do several runs. So reducing the dose is an extremely important thing, and that might be possible using the Kinepict software. But this is the final run using iodinated contrast to see is there any more dissection or some subtle wall changes, and another run for the run-off vessels. As you can see, they do not really look good, but consulting with the vascular surgeons, we decided to stop the procedure look, it's a very good collateralization. Look for the result, and if the healing is not complete, of course, we will go back and we will try a more complicated distal procedure on the occluded below the knee vessels. Another important information that we already mentioned, that we use this 7.5 frame per second program, which is provided by Siemens. And not only the increase in radiation is significant, but the post-processing is unbearable. So if you have a 8-10 second long run, you will have a huge amount of images, and you have to do post-processing, which requires a person just sitting in the front of the computer, the workstation, and post-processing all the time. And that image won't be as quick, or won't be as quickly provided as you can see on the large monitor.
As the DVA does appear without post-processing. Now you can see again the images recorded during these two interventions, and you can compare them. The comments tell you whether it's CO2 or iodinated contrast agents. Right, here we go. Yeah, and this is a screenshot of the Kinepict medical imaging tool, which is, as I said, it's CE marked. And one important piece of information that we expect or hope to get the FDA clearance in the first half of this year. Yes, and thank you, Balázs.
Thank you for having us on board.
So it's back to us now. Please, if you have questions, then we got some. Yeah, so one question came from Professor Caridi. How do we integrate the software? Now, we don't interfere in any sense with the function of the X-ray setup, which is in the catheter lab. So what we do, we take an extra computer there and connect this extra computer to the data output port of the X-ray machine, which is meant to send out data anyways. Take these data, process, and then put a video signal back on the main screen of the operating room. So this way, we don't interfere in any sense with the function of the X-ray setup and the functions that you are used to. You get everything unchanged, but on top of this, you get the DVA image as well on the specified corner of your screen or the screen you want. And then you can use this X-ray information during the intervention. Now yet another question from Professor Caridi. Can you see the software result real time? Now, we don't obtain the data from the manufacturer while you are standing on the X-ray pedal, but once you step off of the X-ray pedal, and this is what you could see on the screen, immediately we start processing. It takes 1 second or maximum 2. You could see on the video, it said data processing, calculating, and then we show you the calculated DVA image. So in this sense, it's real time, is usable in the operating room. And another question came, what frame rate was used? Probably it came earlier than we discussed. So the typical frame rate for the CO2 is 7.5, or an increase compared to the iodinated frames per second. But with the DVA, you can go back down with the frame rate, which saves X-ray dose to the patient and to you as well. Then a question came to Dr. Nemes, Ms. Balázs. How often do you use the software?
So whenever I use CO2, which is pretty frequent, I only use the software. As I already mentioned, the problem with the standard setup 7.5 frame, it's extreme amount of data, a lot of post-processing. The result is not ready in a few seconds, and not to mention, which I already mentioned, is the highest radiation for the personals. So whenever I use CO2, I use Kinepict, and I do not use CO2 without Kinepict.
And yet another question to you. Do your colleagues use Kinepict, or who else is using, or just you? So
actually, I think everyone is enthusiastic about this kind of imaging method. So whenever CO2 is always Kinepict. Luckily, we have the software, and we have that kind of huge monitor which can be divided, and we can readily see the generated image in a few seconds.
Yet another question. Is the software available for a demo or a trial? Yes, it is. Please contact us. You find contact details in the video. You can also find contact details on the kinepict.com website. And then, yeah, we are more than happy to offer you trial periods of this software. Yeah, Professor Caridi commented in the meantime that 7.5 frames per sec is excessive.
Yeah, that's what we think and feel too.
Okay, please click the raise hand. Nobody clicked the raise hand to ask in real voice questions. We got some typed questions. How is the pixel shift done in the operating room?
We don't do it in a OR. It's in the control room, using the software.
So
actually, I use only pixel shift just to see the final result. During the procedure, when I do intermediate images, I don't care about artifacts on the screen. Whenever we are close to the end of the procedure and I want to see the final result in a very, very good quality, that's the time when I ask someone to do the pixel shifting. Usually we do not do pixel shifting even with the Siemens software inside. There is at least 1 or 2 person outside, and that can take care of it.
okay, so apparently we got no questions, but in case you still have questions or later you found interesting questions, please feel free to reach out. You'll find us on kinepict.com. And thank you for your attention.
Thank you.
Goodbye. Bye-bye.